Yes. Oh, I get so close to it. You can hear it? Okay. Excellent. Thank you for your patience, everybody. I am Liz Mann. I'm the PI at the University of Wisconsin. I'm a pediatric endocrinologist, and I'm presenting today with Whitney Beaton, who's our QI champion at the University of Wisconsin. And we're excited to share with you our work in reducing disparities in CGM use for kids with type 1 diabetes. So a little background about us in Madison, Wisconsin. So we're part of the University of Wisconsin at UW Health Kids. Our children's hospital is pictured there, the American Family Children's Hospital. We have our clinics in a few different locations around the city. Our team, our broad diabetes team, is made up of 6 different attendings. We have 3 fellows. We have 3 NPs, 2 of whom are outpatient, 1 is inpatient. We have Whitney, who is our clinical nurse specialist. We have a care coordination assistant, a new position that we gained this year, which has been really exciting. We have nutrition coverage for every one of our clinics. We only have 0.4 FTE of social work, and we don't have any dedicated psychology in our program. Our patient volumes, we have about 850 established kids with type 1. We have about 100 kids with type 2. And we get anywhere between 80 to 140 new diagnoses a year. And I also want to point out or mention here, Rachel Fensky is joining us locally. She's our dietitian and one of our site coordinators and QI champions as well. So our motivation for this work really stemmed from our joining the QI collaborative last year. And we were able to see our map data. And like we've heard this morning, it makes all the difference to be able to see your data and understand where you are in time. You can have a sense of how many kids use CGMs, but we really didn't know. And so we were able to see that kind of like we expected, about 65% of our patients, you can see the mean or the total there is in the teal line. This is right from the QI portal. So if you're used to seeing the colors, that's what you're seeing there. But we noticed that when we stratified the data based on self-identified race and ethnicity, knowing that that's a social construct, we did find tremendous disparity between non-Hispanic Black and Hispanic there in the lower percentiles, hovering around 30%, compared to the non-Hispanic white population, which was even higher than our mean. Similarly, when we look by insurance type, we saw great disparity. So again, the total there is in the teal, with privately insured patients up at 80%, and our Medicaid patients down around 40%. This wasn't super surprising to us because in the state of Wisconsin, MA does not universally cover CGMs for individuals under 21 years of age. They say they require it on a case-by-case basis. And a little more on that later, but clearly that contributes to huge disparity in CGM use. So with that knowledge, we really focused our global aim to say, well, we really need to improve equity in our diabetes technology access because diabetes technology is wonderful for those who have it. And so our smart aim for this project was really to increase the overall percent of kids with type 1. And you'll see in our key driver diagram how we sort of broke that out, but with a goal of increasing from 65% to 75% in this time frame. So we did some work to dig in on why are some kids getting CGMs and some kids aren't. We did a simple clinic survey of some of our providers just for 2 weeks, just like a simple pen and paper, like, okay, the kids who are coming in and not on CGMs, why is that? I think the Pareto tool is super useful. And we found that insurance barriers were the leading cause, which was not really surprising to us. We did break out the other category. I'm not going to go into that much here. But then we found that things like patients not being interested or there were concerns about wearing it were kind of rounding out like the other 80% that you look at in a Pareto diagram. And then we did a process map of what it actually takes to get a CGM initiated in our clinic. And I intentionally made this really small because the details aren't important. But what we learned was, first of all, the process is very complicated and no one person on our team knew the full process from beginning to end. We kind of took 2 key learnings from this. Number one, the process really was quite different for people with private and public insurance because Medicaid requires, they had different requirements because they approved it on a case-by-case basis. They required the separate form. It was kind of this whole other process than private insurance. So that was learning number one. And learning number 2 was just that the process is complicated and there are multiple places to drop the ball. And we really had no way of mapping the whole thing together. But those were very useful for us in being able to create our key driver diagram. So that you can see here with our global aim on top. And then on the left there, you can see our smart aim of increasing T1 or increasing CGM use. And our key drivers here we found are really, number 1, individuals and families being aware of CGMs and how to obtain them. Number 2, like being interested and engaged in wanting to use them. We put specifically our providers across the whole program being aware of the disparities specifically and allying with our aim of improving equity in CGM access. Of course, the coordinated ordering process is one of the major drivers, and then finally equitable coverage of CGMs. And I'm going to turn it over to Whitney.
Thank you, Liz. I'm going to talk about some of those main key drivers and then the PDSA cycles that we did related to each one. So when we talk about patient and family education, we revised and adapted and then adopted some CGM education materials for families. We really wanted to have a standardized way that we were sharing information with families about CGM so that we made sure we were consistent in the information that was shared. We also then took those materials and incorporated them into our standardized CGM education for new onset patients. So this education takes place in the hospital for all of our new onset patients. That's our ideal state. And we were able to incorporate that into our new onset education bundle and really take advantage of our inpatient DCESs and also our interpreter services in the hospital, which are just a little bit easier to access than they can be in the clinic. And also we have families, they're kind of our captive audience while they're there. We also wanted to make sure that our team was aware of our SMART aim and aware of what this project meant and aware of the data that we already had. So we gathered and shared that data. And then we also asked team members to join us if they were interested in working on this project. We worked with our nurses over time to standardize our CGM process so that there was one way to order a CGM. And then along with that, our order process, we created a universal CMN and then worked with our major local DME companies to have them accept that CMN. We're still seeking legal approval for Parachute. We do feel like that will really streamline our ordering process as well, but that's awaiting legal review. And then for advocacy, as Liz mentioned, because we know that Wisconsin Medicaid and our state policies for coverage of CGM in children are a barrier and are contributing to the inequities in CGM use, we joined with other pediatric endocrinologists in our state, as well as the ADA to help lobby for some changes in coverage. So for youth newly diagnosed, so this chart is a P chart for youth with newly diagnosed diabetes who are using a CGM 3 months after diagnosis. So just to kind of orient you to this chart, along the bottom is time, and then the percent of users at 3 months is on the y-axis. And then we've sort of overlaid our interventions on top of the T chart to sort of understand when things happen. So when we think about our ordering process, those appear in blue, and then our education process is more of that pink or salmon color. And so you can see our average in the beginning was 65%. We achieved special cause around November or December of 2021. And we really attribute that to incorporating CGM education in our new onset bundle. And we hope to continue to see this increase over time and sustain that change. And then the second P chart is our graph taken from the QI portal of youth with type 1 diabetes who've been diagnosed for 12 months or more and who are using a CGM. And again, we overlaid those same interventions on this chart. And you can see that we achieved special cause again in that sort of November, December timeframe. And what's interesting is that these patients, our new onsets can't be included in this data yet, just because a year hasn't gone by since they have been diagnosed. And we really attribute this change that we see here likely to just increased team awareness and buy-in with providing CGM to all patients, and then some of it with our ordering process as well. And again, we hope to see this continue to increase over time. And then a little bit more with our advocacy work with Wisconsin Medicaid. So this graph again shows our CGM disparities and just sort of shows our timeline of partnering with others to help advocate for changes at the state level. So we began this work early in June 2021. In January of 2022, we did see some minor changes in the wording for our Wisconsin Medicaid policy, mostly that they removed the requirement for 4 finger pokes a day. It's still a little bit unclear as to whether that's applicable for children or not. But we saw a little bit of an increase, but we continue to work on that. And then our future smart aims are really to sustain and optimize CGM use through connecting with our clinic and then providing further education for patients about how to implement CGM to improve their diabetes management. So thanks to our diabetes team at UW Health Kids, and special thanks to Anne, who's our QI coach.
So I think we're going to move on to the next presentation, and then we'll have time for questions at the end. So our next presenter is Christy Bayer-Mendoza from San Diego, and she'll be speaking about increasing access to continuous glucose monitors, addressing health disparities in technology.
Hi, everybody. Everybody awake? I may not be during this. West Coast to East Coast. Thanks for having us. 2 of my coworkers are here, Andrea and Kim, who also worked on our project with us. This has been an ongoing process. We've been working on this before we joined T1D about 3 years ago. And then of course we get into T1D and it's all full force, and we're still going with it. We thought the project was actually going to kind of sustain itself, but we have more things to do. So the background is we all know that CGMs improve outcomes. I think we're all here and share that. Another background is we had seen that public insured patients had the lowest rates of CGM use. It wasn't prescribing because it was all on their med list. We know it was getting prescribed, it was getting approved. But we found that actually using it and obtaining it and what to do afterwards was lower than what we had expected. There was an audit that was done before we started this process that had found a lot of this information, and that's where we had started, which was interesting. We just heard, and I believe that he's in the audience, education isn't the first step, but that's what we did. It was education and trying to figure out what the process was. And even with the whole process map, what is going on? And we found that, hey, we're ordering it, it's getting approved, and then what's happening afterwards. So our aim statement was to increase our use from wearing a CGM from 64 to 80% in 12 months. We actually have exceeded that, so we're super excited about it. Our key driver diagram, we had put this together, and one of our biggest things that we take away from this that has helped this project tremendously is our pharmacy technician that we hired. I mean, if you guys can get a pharmacy technician, she has helped with so much, not just with the ordering is fine. It's the follow-up. It's the prior authorizations. It's the sending the messages to the nurses and saying, hey, this got approved. The patients picked it up. The patients know how to obtain this device. Now it was passed on to the nurses with education and keeping that usage. Also, we had care navigators that care navigators that do outreach for these patients, these 116 Medicaid patients. What they do is they outreach on different levels, like appointments. Do you know where to get your medications? And so this was added. Are you wearing your CGM? Do you need any help with your CGM? We have with Dexcom, the Hello Dexcom, with the samples that you can give out. So our providers were giving those out inpatient, but the inpatient nurses who were educating patients didn't have any idea what they knew. It was a CGM and a Dexcom. So we did some training on how to help them provide education to the parents. And then also more workflow on ordering and education. And then we always have availability to do education with the parents. We just didn't have a process in place. So if the patients, when the nurses were reaching out, when the patients received their CGMs, if they needed education, we kind of went through a screening, like, do you know how to put it on? Did you watch the videos? Because it seems like we're like, here's all these devices, watch these videos and see what happens. So a lot of education, even though we said that's not the first thing, but the farm tech is the biggest thing. Another one of our interventions from our PDSA cycle is we had a child life specialist that helped us with, we found that in asking the patients why they weren't wearing it, whether it was body image or pain or just that extra support, that the child life specialist was providing Zoom educations with them or one-on-one with them to help them get through that point, not so much of obtaining the device, but wearing the device. These are the interventions that I was just going over. So like I said, it takes a team, but the pharmacy technician was a big one for us to help. Our diabetes team outpatient workflow. When we first started this, we did look at what was our workflow and process and trying to educate, this is our process, but following that process, right? They say start small, the 1 to 2 patients. We had to do that because we were finding that just they weren't following the process, or it was we had such a big process that it was dropping the ball somewhere. The care navigators outreach was our additional support on top of our team of finding out if the patients were actually using the CGMs. Child life specialists as well, that was an additional help, and we still have that support. And then inpatient workflow for the CGM start at diagnosis. What the process was with that, just to give you a little backstory on that, is the providers, our endocrinologists, were taking our samples, going over and putting them on patients. The inpatient nurses didn't even know that they had a CGM on. And so I'm not cracking on, it wasn't Carla. So if she's here, if you guys know Carla, it wasn't her. But then the nurses would call our clinic, like, what do we do? What do we do? So it's just a little more education for the inpatient nurses to know what the device is as well, and what resources they could tell the families is, to do. Because our inpatient nurses do our 3 days of education with our patients, so they don't really have time to add on a device to this as well. And then advocacy, we did with our California Children's Services, we were able to get, a lot of our patients are able to get approved. We didn't have that barrier anymore. Prior to them opening up and approving it, they were requiring 4 times a day blood sugar checks for a month. And that's where our pharmacy technician had helped us as well. So after now we don't have to prove that as much. Now what it is we have to prove that they're wearing it, because now the insurance is like, okay, we need to prove this. So with all these additional things that we have with child life specialists in our education, we can have that documented. So as a result, our results are, we did meet the goal. We actually exceeded the goal, past 80%, and we're reaching 88% about since April. But I think I just saw on the QI portal that we may be just a little bit lower than that, but we're still reaching it. This is our control chart. As you can see, we have done well with all of our interventions, and we need to keep it up. Like I said earlier, we thought this project was like on the side, like, yeah, it's sustaining itself, but as we know, it's not, we got to keep on it. So we did find that with family, patient-centered interventions, support for social determinants of health, it does impact diabetes technology access. And some of the things that we want to do to continue this is we do have a family advisory council. And one of the things that the families had told us is we want drop-in classes. We don't want to have to schedule something and then not be able to make it for education. So our goal is the beginning of next year is to have CGM drop-in classes available every week, so that if they had questions about their CGMs or they wanted more education on it, that they would be able to have a Zoom link and they could just drop in and they don't have to make an appointment. One of the other ones, got on a roll and then lost, is also continually partnering with our child life specialists, because that was an additional tool for us. We do want to increase the number of patients at diagnosis that we're putting on CGMs. So how we can do that, not just our providers, but if we can get our nurses to go inpatient and do that. But we do have, one of our barriers is our Hello Dexcoms. We do have a limited supply, and that could be from our reps. Like, we only get so much because we go through them. You get a box of 15 and they're gone in a day or 2 days. This is the team that has worked with us. The one person that is not up here is our pharmacy technician. I should have screenshot her picture or just held it up. I wish I was zooming so she knew about this, but this was all of our team that helped us with increasing that use of CGM. That went fast.
All right, next we have Ellie Shafarani from Grady Health Systems. And she will be speaking about improving access to continuous glucose monitors for patients with T1D in a safety net hospital.
Hey, good afternoon, everyone. So I'm going to talk a little bit about our process flow for how we increased CGM utilization in our clinic. But just to give you a little bit of a background, Brady Memorial Hospital is a safety net hospital in Atlanta, Georgia. And we see about 85% of our population as Black Americans, and we have about 900 established adult patients with type 1 diabetes, with touch points in the ER and in other centers in the Brady Hospital. We have about 200 patients that actually come for consistent follow-up in the diabetes center. You see our staffing here. We are short-staffed. Full staffing has about 4 RNs. We're down to actually 1 right now. We've recently hired 2 more. So once they have training, hopefully we will be closer to being fully staffed again. We have seen much data on racial and ethnic disparities in CGM use. And so we typically tend to see that Black Americans are using CGMs a lot less compared to white or Hispanic counterparts. And this is another research study that's showing that as well. So what we did in order to build our drivers diagram, we looked at the barriers that are in the data and kind of compare them to the barriers that we see in our clinic. And this is what got the ball rolling and kind of where we wanted to put our focus. And so in our clinic, you know, a lot of the barriers first tended to be insurance eligibility criteria. We were noticing that insurance companies, especially for Medicaid, were requesting the 3 to 4 times a day finger sticks for 30 days. And that was very cumbersome for our patients who already just did not want to stick themselves anyway. And then out-of-pocket costs, a lot of these patients, whether they had Medicare, Medicaid, or were uninsured, the out-of-pocket cost was extremely high, so they wouldn't be able to afford it. In terms of patient provider factors, we kind of noticed that there was a low level of understanding on just using CGMs. And so we tried to increase education by using CGM classes, but we really noticed that, you know, they have to have the device first. So we kind of reframed and sort of thought about what the barriers were for actually getting the device. So what we actually landed on was the amount of paperwork that we had to complete and manage was a lot. And so that is what we focused on for our PDSA cycles. So we have a specialty clinic in our diabetes center. It's called the Glycemic Optimization Clinic. This was started by one of our endocrinologists, Dr. Georgia Davis, who was noticing that there were a lot of patients coming into our clinic with low technology. So about less than 5% of our patients with type 1 diabetes were coming into our clinic, usually because of lack of support, affordability, all of those things. So that's sort of where the development of GOC came about. It is a platform where we can spend more time with our patients, kind of talk to them about the benefits of using CGM and really help them through the process of getting it. The goals of this clinic was to improve glycemic control for our existing type 1 diabetes patients. And we really wanted to prioritize those patients who were coming into the ER for frequent readmissions and currently using diabetes technology who just didn't have extra support. And then also those patients that have significant social barriers that are impacting their adherence or their overall diabetes care. One of the biggest things about the GOC clinic is we do have a multidisciplinary approach. So in this clinic, we have 2 endocrinologists, a pharmacist who is also a diabetes care and education specialist, myself, I'm a dietitian and a diabetes care and education specialist, and we also have a social worker. So depending on the needs of the patient as they come into the specialty clinic, we have availability of all of these providers based on the patient's needs. Just to give you a little bit of a background on how different our general diabetes clinic is and the GOC clinic, I kind of just highlighted the main difference is really the time. We've talked about this earlier today too. There's just not enough time for providers to give the type of care that we know our patients need, especially in a safety net hospital where we're looking at a lot of patients suffering from different social determinants of health. So in our GOC clinic, just to not overwhelm our patients, they're necessarily seeing every provider that's available. We're really trying to assess what their needs are at that appointment and connect them to the appropriate provider. Every follow-up will either dictate whether they see the same provider or someone else, depending on their needs. So this is pulled from the QI portal as well. So you have just CGM use over 1 year. And I've sort of kind of put in where our PDSA cycles were. These PDSA cycles evolved over time, but these are the 3 main ones that we really focused on. So the start of the glycemic optimization clinic was in 2019. So way before we even started being part of the collaborative. But we were able to leverage our PDSA cycles in that clinic. And we started by, the start of GOC clinic, every provider was kind of managing paperwork on their own. And depending on who the patient was seeing, that paperwork would just get lost in translation. We had no idea kind of where the process was for where the patients were, if they were even getting their devices. So it was kind of just paperwork that was all over the place. So what we decided was to just have one person kind of housing that paperwork, not necessarily filling it out, but at least just housing it. So the providers were faxing their paperwork and then putting it in my office so that if we had questions about, anything, we could go back to that paperwork and it was all in one place. I took on that role. Again, we were short-staffed during this year because of COVID. So it was a learning curve for me. So that learning curve lasted several months. But we did see that between April of 2021 and October of 2021, our CGM use increased by to 29% from a baseline of 27%. Then with kind of just managing my general roles, this was just a lot for me. So we kind of recruited our social worker who we found out works well with DME companies for other supplies. So she was also able to take on the CGM paperwork. And she started that in about February of 2022. And then we ended up just recently in April using Parachute. This is an electronic system where we can manage all of our CGM paperwork, and we're directly connected to different DME companies. And it's wonderful because no matter who puts in the application, we are an institution that has access to all of the patients whose applications are in Parachute, and all of us are able to follow those applications so that we don't have to ask the social worker or the dietitian, what's going on with this patient. Everybody has access to that. So that was a really big help. And you can see that in July, our increase in CGM use was up to 60%. This is just a population analysis of our patients using CGM. You'll notice that they're relatively younger, non-Hispanic, Black, mostly on Medicare and Medicaid, and there's just slightly more female patients using CGMs. In terms of next steps, I think one of the biggest things is as we're working through gathering the correct type of data that we need to pull, we were actually pulling CGM prescriptions. And one thing that we really want to look at is true CGM utilization, which is where we created flow sheets to capture this data. So that's still a work in progress. We also want to continue to streamline the process of using Parachute. So right now we're training all of our endocrinologists and other preventive pharmacists to use Parachute for CGM orders so that we're all on the same page and we all have one place to go for this paperwork. And then we also want to continue towards offering CGM classes. I think now that we're seeing that the increase in CGMs are happening, we're up to 60%. We can start to think about, making sure that our patients are continuing to utilize our CGMs and giving them the proper education they need on an individualized basis. And I know we'll go over questions.
Next, we have Basil Murray from Seattle Children's Hospital, speaking about improving continuous glucose monitoring use in adolescents and young adults.
Great.
This is
There we go. Okay, we'll jump in. So really inspiring to see all the great work that everyone's doing, regardless of resource and populations that people are serving. So we'll close out talking about CGM use once more, but hopefully with a little bit of a fresh perspective, thinking about adolescents and young adults in particular. So I'm Faisal Malik from Seattle Children's Hospital, University of Washington. Nothing to disclose. So just a brief plug for those interested in the healthcare transition. Sarah Carruthers and I are co-facilitating a breakout session tomorrow. Encourage you to share your successes in that arena, or if you're starting to think about how best to engage in quality improvement efforts in healthcare transition, please do come. So at Seattle Children's Hospital, we've had the pleasure of partnering with our adult colleagues about 5 years ago at the UW Medicine Diabetes Institute to create a comprehensive program to support the healthcare transition needs of adolescents and young adults, but also their diabetes education and mental health needs. And what's been great about this is, outside of seeing some improved outcomes in patients that have been in our program, it really allowed us to engage in quality improvement efforts specifically for adolescents and young adults, because we were now providing care in a very standardized fashion. So what I will talk about today is how we try to improve CGM use. I think as we think about our baseline data, it's just important to understand how we get a patient into our program and what we mean by their first visit. So again, more on this model tomorrow, but the way it works is that the majority of our patients that come into our adolescent young adult diabetes program or AYA program are from Seattle Children's Hospital. So about 90% are receiving care in our general diabetes clinic. And then what will happen is around 17 years of age, or when a provider or patient feels like it's time to be thinking about transitioning to adult care or becoming more independent in diabetes self-management, they'll be referred to our adolescent young adult diabetes program, and will have their first visit in our AYA diabetes clinic at Seattle Children's. So they meet a whole new team. It's a chance to kind of revisit a lot of their educational needs in addition to the healthcare transition needs. There is a small subset of patients, though, that will enter our program on the adult side of our program. So for example, let's say it's a patient that is coming to the University of Washington, that's an 18-year-old that's going to start college there. They're going to obviously need to establish care at an adult institution, but here again, they'll have the opportunity to enter our adolescent young adult diabetes program on the UW side and get their needs met, knowing that adolescents and young adults are very different than older adults on the UW side. So as I talk about the baseline visit, it's that first visit either on the Seattle Children's AYA Diabetes Clinic or on the UW side. So why was this important to us? I think everyone here is familiar with the data. This is actually, I just always love highlighting T1D exchange data. This is Dan DeSalvo's paper from last year, just highlighting that 13 to 26-year-olds have a lower proportion of CGM use compared to other age groups across the lifespan. So when we looked at our data, so again, this program started 5 years ago. Back in 2017, about half of our patients were using CGM, and so we wanted to improve that, aligned with what we've been seeing in the T1D Exchange Quality Improvement Collaborative. So for our SMART aim, we wanted to increase CGM use in adolescent young adults with type 1 diabetes by 10 months. And that was after being a year in our program, so that's going to be important. And since it was a new program, it's taken us several years to kind of look at the data. And we had a chance just recently to look at about 4 years of data, which I'm going to present with all of you. But I think the key piece when you're thinking about quality improvement work is thinking of what are the key drivers to that are leading to the outcomes that you're seeing, and how can you improve them. For us, we focused on identifying 4 key drivers: patient and parent education, provider prescribing behaviors, health insurance barriers, and then patient-reported barriers to CGM use. Of course, there are many more that have been highlighted by some colleagues earlier on during this breakout. So how did we want to address these key drivers? So here were our change ideas. Again, we had an opportunity to revisit diabetes technology education. So even if there was a handoff by a previous provider saying, hey, I've talked to them about CGM, and they said they didn't want it, we would make sure that everyone got diabetes technology education at their first or second visit in our program. So again, just making sure that the patient and parent education needs were being met, particularly because all of these patients are going towards college and getting increased independence, and there's a chance to revisit some of their previous beliefs and preferences. We also made sure to provide access to video interpreters. This was really important during the pandemic to facilitate education and training in patients' preferred language of care when we didn't have in-person interpreters. And then this has already been highlighted, but offering CGM samples to support a trial period was like a really big win. Some of the best ways to educate a patient is to give them an opportunity to try something. And so, with Hello Dexcom coming out in 2019, that really made that program even more robust. And we, of course, created educational material. In terms of provider prescribing behaviors, again, oftentimes, providers will make judgments about who's a good candidate or not. And by offering standardized education, we knew everyone was going to get a discussion about diabetes technology. We also coordinated implicit bias training for our providers. Again, we were able to do that because we had a little bit of a smaller team. From a health insurance barriers, in Washington State, back when this program started, many public insurance programs required 30 days of glucose meter data. You guys probably remember those times. We've obviously made a lot of headway. So the way we got around with it for adolescents, young adults, we knew they weren't going to check. So we're like, hey, here's 3 samples, wear the CGM for 30 days, and we'll get you that CGM. Obviously, it's amazing the things that we have to do to advocate for our patients. And then this has already been highlighted. We also hired a durable medical equipment coordinator. Makes a lot of difference to have someone navigating your insurance process. And then finally, in terms of patient-reported barriers to CGM use, I think this has been talked about by others. We have a psychologist that's part of our program. And so again, having not only screening for mental health comorbidities, but having the opportunity to address some of those burnout issues or body image issues really went a long way. Several of my patients got cognitive behavioral therapy and really had success from that to be able to put on a CGM when they weren't willing to do it previously. So that's our key driver diagram in full. I think the biggest piece, and that's been highlighted, is just we know there are differences between race, ethnicity, and health insurance status. So I thought we've seen some run charts. So you can do a quality improvement project, but it's always okay to also use standard regression methods, particularly if you're trying to think about how can I adjust for confounders like health insurance and race ethnicity. So that's what I'm going to present, just to kind of mix it up a little bit. Those who want to see a run chart, happy to do that too. So we included data for patients that were from 2018 to 2022, who had at least been in the program for 6 months. We used generalized linear models to calculate proportions and 95% confidence intervals. The big thing is we adjusted for confounders, and then we wanted to see, was there a difference in our population in terms of baseline by health insurance and race ethnicity, and was there a differential impact as the patients received care in our program? So just to give you a big picture, so there's about 526 patients in this sample, half male, half female. We live in Seattle, so non-Hispanic white population is our largest representation, so 72%, and about 30% were on public insurance. So here's the data. On the x-axis is approximate months after baseline visit. On the y-axis is proportion of patients with a prescribed CGM. You can see at the first visit, a little over 60% were using CGM. By 6 months after their baseline visit, we're getting close to 80%. And by 2 years in our program, about 90% of our patients are using a CGM. But what was more exciting was looking at, again, that people have done such a great job talking about disparities today, is that we saw that at baseline when patients entered our program, and again, these were patients from Seattle Children's Hospital, there was a difference between CGM use, whether you're on public or private insurance, and that's highlighted here. You can see that about 50% of public insurance patients were using CGM, and then close to 65% for private insurance patients. And you can see that these confidence intervals don't overlap, so there's a statistically significant difference. But what was really rewarding for our group is by the 6-month mark, you can see that gap has closed. We see a comparable use of CGM, about 78%. Whether you're in public or private, the confidence intervals are now overlapping, and kind of that theme stays true throughout the time period while they're in our program. So in conclusion, we're really excited that our program really felt that we not only increased CGM use, but mitigated health insurance disparities. A lot of our change ideas were able to be implemented over time, and it's been a fun project to work on. So as everyone always talks about, it takes a team. Alyssa Roberts is here, who's one of our providers and really helped launch our program. And we've got a great nurses, psychologists, social worker. We're well resourced. That always helps. But I think the key piece is that the combined change ideas really made a big difference. So thank you for your time.
Well, thank you to all our presenters for making a difference and sharing their strategies for increased CGM use. Now some time for questions.
All really fantastic. Work. I have a question for Alisa about the glycemic optimization clinic. Just the practical aspect of scheduling patients into a clinic where you might have to see multiple providers depending on your needs. Is that like a resource? And then you pull them in and what's yeah, sure. Sorry.
I was just asking for the glycemic optimization clinic at Grady, where patients might need to be seen for different reasons, how it's operationalized in terms of scheduling and then billing. So it's a longer visit. How did you handle charges, and was that acceptable by patients?
Yeah, so we get referrals to the glycemic optimization clinic from our general follow-up clinic and then from the emergency room from our inpatient educators. And so they send us those patients through an Epic message, and we're able to schedule them on our own depending on how much space we have. It is one resource, and on the day that the patients come, we usually have a meeting with our core team to discuss who needs to see which patient and what they're here for. Typically, any patient that's starting in the GOC clinic will always see an endocrinologist and be assessed with what their educational needs or social needs are so that they get connected to the appropriate provider moving forward for their follow-ups. In terms of charges, sometimes they will see an endocrinologist and, an educator. And I think our patients are pretty well prepared for the amount of time they're going to spend. In general, our wait times are pretty long, and I think our patients are pretty used to it. But I think what's helpful is that they're getting what they need out of the appointment because we're asking them what they need. And so I think they're definitely okay with spending that time, knowing that they're going to walk out with what they're needing. And then charges are just based off of kind of who they're seeing. So there is some overlap, but it tends to work. Sure.
How much time is allotted for GOC visits? Also, which supporting staff provides care during these visits?
Sure. So these visits are about 60 minutes. We schedule patients every 30 minutes because, again, not every provider is seeing every patient. And so when we are discussing which provider is seeing whom, the appointments are about 60 minutes long. The supporting staff that will see these patients are, again, not everyone is seeing these patients at every visit. So it just depends, again, on the patient's needs and what has been decided by the endocrinologist. And so the initial visit will be an endo appointment, and they will sort of write out a plan of maybe we need to focus more on education, carb counting, or CGM utilization, or things like that. And they will give those patients in the follow-up visits to the educators at that time. If it comes up in the appointment that a patient is needing, social resources, then they will definitely pull in the social worker to come in on a same day appointment and kind of just give them the resources they need. So I think we're really just trying to figure out, once the patient comes in, for the most part, what their needs are, and then connect them to the appropriate provider at that time.
Hi, I have a question for Christy. I wanted to know, have you found a way to be able to get supplies, CGM supplies for patients that have no insurance or that the insurance completely denied their supplies?
Like, where is Natasha? These are Natasha questions.
That's a great question. As far as insurance and not having insurance and supplies, Natasha usually works her magic somehow. Yeah, I don't I'm gonna go with like Kim and Andrea, like, do you have? Yeah, Andrea's also a nurse educator working on this project.
Hi, I'm Andrea. We're lucky in California because we have what's called California Children's Services, sort of complementary to Medicaid. And so if you have the diagnosis of type 1, it's only given to people with certain diagnoses, but type 1 is one of them. If you have that diagnosis, you're covered, as long as you meet the financial criteria. So we are really lucky that way. So most of our kids are covered. We don't have a lot of completely uninsured people.
Yeah, and I think for our private patients, like I had said earlier, it's, you know, they have to show that they're using it. Yeah, thanks. Yeah, my question's also for you, Christy. You mentioned that you have care navigators for 116 patients. How many care navigators, and then who pays for those also? Well, I'll see if I can answer this. This is usually Kim's department too. So there was, oh gosh, I don't remember how long ago it was, but within the children's or CCS population, there was funding, a grant funded for what we called California Kids Care. And so that's where these care navigators came from. So all the money came from grants from an outside source. The care navigators, I believe currently right now there's 3. Okay, I'm like, I've got this good. There's 3 care navigators for that 116. They may be up to like 120 now. They it's not an enrollment. It's sort of like, these are the patients we followed before. They call the families and ask, like, do you want us to help follow you? So what happens on the outside with the care navigators is when they're making these outreach calls, if they find anything that needs to be addressed, they send us a message to our clinic and say, hey, I talked to the families. These are some things, you know, they're talking about maybe having highs or lows, or they're not able to get their medications or their pump supplies. And so they send us a message for us to follow up, or for the pharmacy technician to follow up as well. So there's 3 for about 116. It's not us. It's not our division. It's still a grant funded. Well, I think they're showing outcomes as well. So we're collaborating together. Dr. Carla Dimiterico, who is our PI, she helps with all that and with providers. So some projects that she's done with that is lost to follow up. And so she's really gear-headed towards that, where the care navigators are helping us. So it's just an additional resource, but we are not paying for it. Yeah.
One question for Dr. Malik. My question was, I see you have 2 transition coordinators that are in yet, or what's their role and what's their responsibility? How do you fund it?
Yeah. So the question was about our healthcare transition program. I'm sorry to get your name, sir. Roberto asked about how our transition coordinators are funded. So as you guys know, probably the biggest challenge in getting our pediatric patients to an adult site is putting that referral in, having those connections, and then making sure that they actually show up. So since our program is a combination of both Seattle Children's and University of Washington, what we do is close this really quick to show you how it's structured. So what will happen is we actually have a transition coordinator on the Seattle Children's side. In terms of funding, it started as a grant funding operation, but now over time we've been able to demonstrate our impact to our hospital. So the hospital actually funds the Seattle Children's transition coordinator. So they'll put a referral in and talk with the UW side. We initially had 1 transition coordinator for trying to cover both sites, but as you know, like both health systems are completely different, and we realized we needed a transition coordinator on the UW side as well. I'll tell you that part, the UW side is right now grant funded, but our hope is we'll be able to make the same case for why this is valuable. So we've leveraged and so again, we didn't try to go beyond, because we wanted to keep the funding and hopefully have the hospital do it. We leaned into our kind of scheduling and admin department, and so added some FTE for them initially, and then they were able to kind of maintain that work. So some models will have like a full transition coordinator who are doing a lot of different things. Our transition coordinators are simply focused on making sure that the patient actually moved from Seattle Children's to the University of Washington successfully. Yeah. Absolutely. Yeah. So that's that. Yes. The question is a really good one is what do we do for our patients that may go to college and or going out of state or move for a job, and how do we track them? So at this stage, are we plan to submit a grant to be able to follow people long term? Well, I'll just tell you in terms of what the strategy that we've used that's worked really well, probably the hardest time for this population is the college period, because they have a hard time finding a local provider and are still coming home. So what we do, our program is really designed to keep the college students as long as they're in Washington State. Obviously, when it was during the pandemic, we were seeing people in California and we're like, we'll see you over telemedicine. So what we try to do is see them over telemedicine if they're in Washington State, and then try to get one visit during a break. So that allows us, because the college period is the hardest time, they're oftentimes still coming home. So as long as they have a Washington address, and usually it's still their parents' home address, we'll have them come home and get their annual visit that way. And that allows us to track them through college, probably the period that we oftentimes lose a lot of our young adults. So that's at least how we approach it. Since a lot of the patients, and what happens is because our program helps them go to the University of Washington, once they're plugged in, their local adult endocrinologist winds up being at the University of Washington, unless of course they move for job or other educational needs. That's a great question.
Have you utilized the professional CGMs unblinded to bridge the gap sometimes? And the coverage seems to be larger issue for above 18.
Yeah, I can talk. I want to make sure that other people get to talk about it too. Has anyone used the? So we haven't used the professional because I'll tell you that usually we just try to get the sample on the page because you want them to. So was the question to whether you want to do the blinded? Is that what it was? I'm guessing it was blinded, but the idea is that unblinded. I'm sorry. Yeah. So yeah. I mean that's what we do. So I guess that's when. Yes, the answer is yes. The whole group agrees. I think it was only if there was like maybe some value in doing some blinded. That's like a different question.
The question is like, we don't do hello Dexcom.
Okay.
One, we'll try and get a Dexcom on it, but we're not doing samples.
Mm.
And then for those that are borderline, we are sending them for diagnostic CMS, and that they also get that time with their CDE to learn about it.
Sure.
Training and to get it put on, and then they get feedback. So I guess open to everybody, what process, obviously, probably patient dependent, but everybody else can diagnostic CMS as a first line.
We deal with adolescents and young adults, so we don't. But if others people want to chime in, I'll save the podium.
I think professional pediatrics. Yeah, and not a lot of sampling because of the cost of the device that violate our policy. That's why we have used professional CPM. Any other questions?
I'm Lily Chow from Children's LA. In this world where we are short-staffed on every level, I'm curious what everyone's institution is doing to support CGM education, device education, when I imagine most places are not staffed to your usual or desired. How does everybody do it? I feel like we can't ask one more thing of our CDCSs.
best practice in there. We're talking on already on CGM, then the compounds to have. And we're bunching them back to Dexcom, actually, so like, call your Dexcom rep, and they're supporting a lot of the questions. Put people on early on, because we're getting bombarded with phone calls, so every fast Dexcom.
We often see patients that we want like 2 weeks or 3 weeks after, we put the hell of. So they can be educated, or then they see that time to address some of the questions. Then we've been very successful with that.
We have RN and RD educators. I think everybody kind of absorbs all of that. And when we're all kind of maxed out, we also leverage our interns and residents and fellows, train them to do some of the education. Even though they're kind of short-lived in our clinic, at least that takes off some of the pressure of us having to do all the educations. So they take on a lot of that as well. Even my iPad.
We did develop as part of our process at Candle, called it CGM 101. And it just has some main points about like, what is a CGM? How can you benefit from it? How will you get a CGM? Like, where did you order it? What should you set your alarm limit at when you get it? Because we also found that like you're presenting this at your diagnosis when you're just getting overwhelmed with so much information, and families often don't leave the hospital with it because through the prior authorization process that they pay for most of the insurances that we see. We did find that handout has been helpful in sort of standardizing the information that families get and also being a resource when they go home. We've also tapped into Dexcom, who's really helped support some of our education. And they just seem to have time that we don't have for like especially special cases that maybe need a little bit of extra thinking. Final thoughts, questions? All right, great. So thank you everyone for your time today, for the great presentation.